Hi, this is Dr. Pedro Ramirez, editor-in-chief of the International Journal of Gynecological Cancer. And today I have the great pleasure of having back on the podcast Dr. Roni Nitecki Wilke from the Department of Gynecologic Oncology and Reproductive Medicine at the University of Texas MD Anderson Cancer Center here in Houston, Texas. The topic of this discussion is a recent publication in the great journal, the American Journal of Obstetrics and Gynecology, titled Salpingectomy in Individuals at High Risk for Tubal Ovarian Cancer, Consensus and Precaution. Roni, thank you so much for your time, for accepting our invitation, for joining us on the podcast once again.
Oh, thank you so much, Pedro, for the opportunity to speak with you. It's always an honor to be part of this podcast.
Well, great. I have quite a number of questions, and certainly, obviously, wanna hopefully, ideally, cover all of them. So let's start by asking, what do the current guidelines tell us about risk-reducing salpingo-oophorectomy? Which patients and when should it be performed?
Yes, absolutely. So, individuals with hereditary predisposition to tubo-ovarian cancer are recommended by the NCCN and guidelines in other countries as well to undergo a risk-reducing salpingo-oophorectomy between the ages of 35 and 40 for BRCA1 carriers, ages 40 and 45 for BRCA2 carriers, and starting at ages 45 to 50 with individuals with pathogenic variants in moderate penetrant genes like RAD51C or D, BIPROM, and PALB2. It can also be considered for patients with pathogenic variants in genes that are associated with Lynch syndrome.
Excellent. So we'll actually get into the questions from our fellows. This one comes from Matteo Lovero, Policlinico Gemelli in Rome, and he's asking, how strong is the current evidence supporting opportunistic salpingectomy in women with a family history of ovarian cancer, but negative germline testing, and more broadly, in average risk women?
That's a great question. In general, I would say that the data for family history and negative genetic testing is still evolving. Even in the presence of negative germline testing, there probably is residual increased risk that's mediated by family history, but there's no strict guideline, meaning that the recommendations are individualized according to shared decision making with the patient. In terms of general population risk reduction related to opportunistic salpingectomy, we have fairly good safety and feasibility data, and we have some efficacy data, primarily from well-done observational studies, coupled with excellent biologic rationale. So while I think we will have stronger efficacy data in the future as we get more and more prospective data, there's very little downside and a huge potential upside in adopting the strategy for patients at average risk undergoing any surgery. And this is reflected by national guidelines in multiple countries.
Okay. Paula Mateo from Houston Methodist actually is interested about the actual technique, and she's actually asking, what is the recommended technique for pathologic evaluation, and how many serial sections at what interval are needed to adequately assess the fallopian tube?
Well, I am not a pathologist, so grain of salt. But my understanding is that there aren't a fixed number of sections completed, but rather it's completion of a systematic process to capture multiple thin sections from the fimbria and the main tube every 1 to 2 millimeters. And the point of this is to maximize the examined surface area, ensuring that almost the entire specimen is reviewed for microscopic changes. I'll never forget, I think it was SGO last year, when I heard a provider from another country say that in the past, pathologists in their country used to just throw away the tubes. They wouldn't look at them at all because they didn't think there was any purpose of looking at them. So this is a very far departure from that approach.
Amazing. Yeah, amazing comment. So now Mo Byrne from Memorial Sloan Kettering in New York, she now wants to get into the definitions of delayed oophorectomy. She's asking, how do you define delayed oophorectomy? Presumably, there is a difference between early salpingectomy and oophorectomy still within guideline care timeline, and salpingectomy with interval oophorectomy far past the recommended age of ovarian removal.
Yeah, those are some great points and great questions. There really is no standard definition for what we call delayed oophorectomy. The protocol that we employ in Tubo WISP 2, which is one of the studies we discuss in this opinion piece, is that patients get an additional 5 years with their ovaries beyond the maximum age guideline. So for BRCA1, that means we recommend completion oophorectomy by age 45, and for BRCA2 by age 50. This definition is different for another study that's called SOROC. And certainly, there may be risk reduction differences based on when the ovaries are removed and if they're removed at all. But we don't have enough data to answer these questions currently. I certainly hope we'll have enough data in the future through these studies.
Yeah. A follow-up question from Mo. She's asking, how would you factor in patients with a family history of ovarian cancer, but no known mutations similar to the prior discussion into this risk group and your recommendations? While lower lifetime risk compared to known mutations, it's still higher than the general population.
Yeah, another great question. So, as discussed earlier, even in the presence of negative germline testing, there probably is residual increased risk that's mediated by family history, but there's really no strict guideline about what to do. So, it comes down to a conversation between the provider and the patient. A patient with negative germline testing would not qualify for these trials that are looking at risk-reducing salpingectomy followed by delayed oophorectomy. But I think the counseling should be similar in terms of risks and benefits in the setting of a higher than average population risk of developing tube ovarian cancer.
So, Master Pervin from the University Hospital in Münster, Germany, she's actually also interested in the two studies that you mentioned. She's asking when ovaries are removed after prior salpingectomy, residual fimbrial tissue is seen in 10% of the ovaries. Should the clinical significance of the residual tissue not be evaluated at least at the same time as the tuba wisp and SOROC trials are on the way with anticipated results in 2036?
Yeah, ideally, yes. We're not currently powered to look at that question. And truthfully, like until the ovaries come out at a second surgery, you don't know that there was delayed fimbria, right? Nobody does a salpingectomy with the intention of leaving fimbria. But I think this underlines the importance of why we wanted to write this opinion piece in that these surgeries are happening in the community. And not every patient is going to have access to a clinical trial. And if these surgeries are happening in the community, we want them to be done sort of with the best possible surgical approach and the best possible outcome for the patients if they cannot be on a clinical trial.
Yeah. So this next question from Itzi Villagra in Madrid turns over to the topics of the after effects. And she's asking, you mentioned that premenopausal oophorectomy can have irreversible effects on quality of life by causing vasomotor symptoms, sexual dysfunction, and mood changes. What is the primary reason why women choose not to undergo the surgery?
So, qualitative research would suggest that quality of life impairment related to premature menopause is the most troubling for patients. Anecdotally, I really think it's a nuanced individual decision because no woman knows exactly how she's going to feel once she's actually in menopause. For some women, it's a concern that they won't be able to alleviate their symptoms with HRT if they have a history of breast cancer, for example, and they cannot use HRT. For others, their main concern is sexual dysfunction or increased risk of cardiovascular disease. So I think it's all of those things together. I also think that menopause, at least in this country, is having a moment. It's becoming more and more sort of non-taboo to talk about. And women, I think, are more and more advocating for their ovaries to remain in place because of this kind of new focused attention on both the short-term and long-term consequences of menopause.
Yeah, great question, and leading to the topic brought up by Mateo Lovero here on HRT, hormone replacement therapy. As you mentioned, menopause now becoming increasingly more a focus and a highlight in the discussions with our patients. How does hormone replacement therapy fit into the counseling for high-risk individuals, and could effective symptom management influence a patient's decision between immediate risk-reducing salpingo-oophorectomy versus risk-reducing salpingectomy with delayed oophorectomy?
I love this question. In general, in the absence of a personal history of breast cancer, HRT is not contraindicated. And moreover, estrogen alone has never been shown to increase the risk of breast cancer. And there are actually some prospective data that for BRCA1 patients, estrogen alone may actually be protective against breast cancer. But there's a lot of fear surrounding HRT, and it's prevalent, unfortunately, both among patients and providers. And some oncologists do not recommend HRT for patients with BRCA mutations. And I would say that's really in the absence of any robust data. So for the HRT question in my practice, I have found that it is not that straightforward. And I do think it influences the risk reduction strategies that patients take because of a lot of fear around HRT.
Yeah. Thank you for bringing light to that particular topic. And, again, I agree with you. There's so much misconception about the use of estrogen and estrogen replacement in patients with prior family history or even prior history of cancer. To the next question, Masha Pervin from the University Hospital in Münster, Germany, she's asking, in the TUBA study, participants who receive hormone replacement therapy after risk-reducing salpingo-oophorectomy still reported a significant difference in the climacteric scale. Does this not mean we need better management of hormone replacement therapy?
Yeah, I think it's an excellent point that HRT does not solve all the menopausal issues related for patients. And I think it's just a really important part of counseling. Um, I don't know that better management of HRT would solve all of the menopausal problems for patients. I mean, I think it is likely that for some people, nothing is as good as their ovaries.
Absolutely. A bit of a controversial question from Joanne Nouveau in St. John, Newfoundland. She's asking, we won't have the results of the prospective trials until 2036. If risk-reducing salpingectomy followed by delayed oophorectomy turns out to be inferior to risk-reducing salpingo-oophorectomy, who's going to take responsibility for the women who develop preventable cancer because we shifted a practice prematurely? Basically, are we prepared to tell them they were part of an uncontrolled real-world trial?
So that is a huge reason to do the strategy on a trial and for patients to be on a trial. Um, on a trial, there is record and patients can be notified if we find that this alternative strategy is not non-inferior to the standard of care. I think this question underscores the importance of the consent process. I think everybody that consents patients onto these trials takes great care in making sure the patients understand that this strategy is not standard of care and we don't know if it works. This is also the reason that this could never be a randomized control trial and is a patient preference study. Um, right, there's no real solution for patients that are undergoing this strategy off of a clinical trial. Um, I'm hoping that we could at some point start a registry for those patients so that once we have results, we would be able to contact patients that had received this strategy off trial.
Excellent. Mathilde Dell from Toulouse, France. She's asking more about what you do with your patients. Do you recommend performing preoperative examinations like a pelvic ultrasound, a CA-125 before undertaking a risk-reducing surgical procedure?
I think it can be helpful for preoperative planning and counseling. And NCCN, the National Comprehensive Cancer Network guidelines, actually do recommend a CA-125 and ultrasound for this purpose. We've all diagnosed cancer in somebody with negative pre-op workup, but those cases really are few and far between. I think if you find that somebody has abnormalities on their pre-op workup, like a mass on their ultrasound, it is helpful. With those patients, I do spend more time discussing frozen section, staging, etc. So I think it can be helpful, and it is recommended by our national guidelines.
Okay. Another question from Matilda. She's asking, in the case of risk-reducing salpingectomy, at what age do you recommend performing the completion oophorectomy? And does family history and age at which cancers occurred influence your recommendation?
Great question. So I recommend completion oophorectomy as per the protocol of TUBA WISP-2 if the patient is on the trial. So on the trial, you get an extra 5 years with your ovaries beyond the maximum guideline age. If the patient is not on trial, I would recommend a completion oophorectomy by the guideline age and not quote unquote a delayed oophorectomy, which is something that we use on trial. In standard clinical practice, family history does influence my counseling. But again, in the trial, the recommendations are uniform regardless of when a family member developed ovarian cancer.
As a follow-up to that, Tommaso Meschini from University of Insubria is asking, considering the psychological stress experienced by women carrying germline mutations, based on your clinical experience, do you think it is a reasonable option to consider an earlier prophylactic salpingectomy before the recommended age for oophorectomy, specifically for BRCA2 carriers or patients with variants of incomplete penetrance for whom oophorectomy is typically advised at 40 to 45? Could a salpingectomy around the age of 35 be a viable option?
Absolutely. I think it's a very reasonable strategy for someone who wants to do quote unquote something before the minimum guideline age, but is not ready to part with their ovaries. We have data from the original WISP study, which was powered to look at psychosocial outcomes, and found that patients who underwent a bilateral salpingectomy were satisfied with their procedure. They had decreased cancer worry and decreased anxiety after the procedure. So I think this is a very reasonable strategy.
Hmm. Paula Mateo from Houston Methodist is asking, for oncologists who think risk-reducing salpingectomy with delayed oophorectomy offers the same level of risk reduction as risk-reducing salpingo-oophorectomy, what key points do you emphasize to explain why that approach is not recommended?
I try to explain the lack of data. The fact that the study is powered to actually look at the non-inferiority of the strategy will not have results for many years to come. I think this is particularly important, this lack of data, because risk-reducing salpingo-oophorectomy has reasonably strong data demonstrating decrease in mortality for patients with BRCA mutations. So, we have a strategy that works and works well and saves lives. And this alternative strategy definitely has some benefits in terms of quality of life, but we just don't know. We don't know that it's non-inferior. And so I just try to stress that it has good biologic rationale, and that's why we're doing this study, but we really don't know, and we will not know until we see the outcomes around 2036.
Excellent. Another question from Joanny Novo, and remember, she's in St. John's, Newfoundland. So to this question, she says, considering that most cases are being done by general gynecologists, not specialist gynecologic oncologists, general gynecologists without access to clinical trials, what would you recommend to a 36-year-old woman with a BRCA1 mutation? Would you tell her to do a risk-reducing salpingectomy and delayed oophorectomy, or a risk-reducing salpingo-oophorectomy?
I would have a discussion with that patient. I mean, in general, in my practice, I really only offer risk-reducing salpingectomy with delayed oophorectomy on trial. And I really try to stick to the guidelines for patients that are not on trial. I think for patients that are looking to have this surgery done in the community, the pathology is really important. So, CFIM or the serial sectioning of the fallopian tube that we discussed earlier is really, really important. And if that is not done in the hospital in the community, or you're not sure if that's done, then I don't think this is appropriate to offer, to be completely honest.
Excellent. So, Ronnie, one last question from our fellows, Carlota Sabini from Milan, and she's interested in what to do after in terms of surveillance. So she's asking, what type of clinical and imaging follow-up do you propose for your high-risk patients who undergo risk-reducing salpingectomy with delayed oophorectomy outside of these clinical trials?
So there's no evidence to suggest that screening with CA-125 and ultrasound is beneficial. A lot of money, a lot of effort has been put into trying to figure out a screening algorithm for ovarian cancer, and even in the highest risk populations, it just doesn't rise to the level of being able to decrease mortality for these patients. CA-125s and ultrasound used to be recommended by NCCN, but they actually stopped recommending that a few years ago. So I don't think that there's a compelling reason to perform these tests for patients, whether or not they're on the trial. I do think it is important to have a home for patients to check in with providers and to have discussions about their ideal strategy for reducing the risk of ovarian cancer. And so, for example, we have a clinic here at MD Anderson that's called the Ovarian Screening Clinic. And I don't like that name because I don't think screening works. And I don't think we have evidence for screening, but that's sort of the historic name that it has. And even if patients choose to not have screening, I think it's important to have a provider to talk to have somebody to see once a year, to check in, to ask them, when are you having your surgery? Have you thought about surgery? Have you thought about how you're going to decrease your risk of ovarian cancer? I mean, this is for these patients, in the vast majority of cases, a preventable cancer. And I think it's really, really important because, as you know, once ovarian cancer is diagnosed, it is largely incurable. And I think these patients have a real shot at being able to prevent it. So having a home for them to go to seek advice, to talk about the options is really important. But the screening itself, the ultrasounds, the CA-125s, there's no evidence that it truly decreases the mortality from ovarian cancer, which is why it is no longer recommended.
So, Roni, in our podcast now, as the last question, we always ask AI for the question related to your article. And the question that was posed by AI on your article is the following. Is this clinical opinion unintentionally legitimizing an unproven strategy by framing risk-reducing salpingectomy and delayed oophorectomy as a reasonable alternative, thereby accelerating its off-trial adoption despite the absence of any mortality or cancer incidence data and the existence of a proven life-saving standard such as the risk-reducing salpingo-oophorectomy?
Such a provocative question from AI. It's interesting, the obviously when you write, you go through different drafts and your message, while keeping the core, can change over time. And I think this happened while we were writing this opinion. Initially I wrote it to say, you shouldn't do it off a clinical trial. It is not ideal. And I think the language softened as thinking about it and writing it and sharing it with other authors and sharing it with reviewers. I think at the end of the day, like, getting on a clinical trial is hard and it's not something that's accessible to everyone. And it's hard to say, like, you should only do this as part of a clinical trial. I think there are reasonably safe ways to have this strategy done. The issue is that the counseling is really, really important, and patients really need to understand that a risk-reducing salpingectomy is not the same as a risk-reducing salpingo-oophorectomy, and we do not currently have the same level of evidence for it. We have no evidence that is as efficacious as a risk-reducing salpingo-oophorectomy at this point. And what I hope that this manuscript does is not necessarily quote unquote legitimize doing this strategy off trial, but really help empower practitioners to have a really good conversation with patients. And if patients still really, really want it off trial, understanding the risks and understanding the lack of evidence, then to have some pointers about how to do it in the safest way possible. So thank you, AI, for this provocative question.
I think you tackled that question incredibly well, and I think AI will be very, very pleased with that response. So, Roni, thank you so, so much. Again, always such a pleasure speaking with you. I learned so much every time I listen to you, and again, continue your long-standing trajectory of really providing great literature for the field of gynecologic oncology. Certainly, again, extremely proud of personally having taken part in your training and I really admire you and I think I also recognize and commend you for being such an amazing role model for many young gynecologic oncologists. So thank you.
Oh, thank you so much. It's such an honor and such a privilege to be able to talk to you and to be on this podcast. I really appreciate it.